All right, today we're going to be talking about how to approach an MRI of the brain. This is an MRI of the brain without contrast. You're first going to start off by looking at the history and the indication. You're going to figure out why the exam is being done. Is this a stroke study? Is this a seizure study? Dementia study? These things are all going to dictate what kind of series to expect and kind of change your pretest probability for certain things. When you're looking for adequacy, you're looking for, is there a significant amount of motion? T2 sequences tend to be very motion degraded as they take a while to obtain on most modern scanners. So you look at your T2, see if there's a bunch of motion. Look at your sagittal or your localizers, see where we're looking. The MRI of the brain should include from the vertex to the foramen magnum and typically parts of the upper cervical spine. Make sure that this is an appropriate study to dictate. So when I'm reading an MRI of the brain, depending on the indication, this can vary, but in general, I'll start with either the T2 or the FLAIR sequence. I'm going to be looking at my anatomy. So what I do is I actually look at the brain first. I'll break it up by lobe. So I'll look at each one of the lobes on either side. So starting with the frontal lobe and then going through the contralateral frontal lobe. And then I look at the temporal lobes, follow the temporal lobes on either side, looking for any abnormalities. On T2, I'd expect a bright signal. Look at the occipital lobe, the parietal lobes, going all the way up to the vertex and coming down. Again, this is abbreviated. You'd be much more thorough, but break it up by lobes. Then you look at the basal ganglia. We're looking at the thalamus, and then ultimately the brain stem, the medulla, the pons in the midbrain. And then once we're down here, we're going to be looking at the posterior fossa, the cerebellum. On the T2 or FLAIR sequences, you're looking for any white matter changes, any edema, any abnormal cortical signal that can indicate some sort of neoplasm. On the FLAIR, which is the most sensitive for these kind of T2 signal changes, you look for the subcortical white matter to see if that there's any white matter disease at baseline. You're looking for cerebral edema. Basically, this is going to be your number one sequence for identifying abnormalities. Once I'm done with the intracranial structures, I'll then look at the extracranial structures, looking at the skull, looking at the orbits, the lenses, the retroorbital fat, the facial, fat, musculature, and then the nasopharynx and the oropharynx, just making sure I don't miss anything as you're responsible for all of these. Next, you'll move on to the DWI. DWI is diffusion weighted imaging. This is what we use to identify strokes. In general, it can also identify other things, but in general, it's strokes. You're looking for bright signal on the DWI. So again, going lobe by lobe on the intracranial structures, looking for anything that pops out that's bright. If I see something bright, I'll look at my ADC map, which should, if it's a infarct in the case of a typical routine brain without, it should be dark. So corresponding to to an acute infarct. So that's going to be my DWI. You look also in the scalp on the DWI. Sometimes, particularly patients with melanoma, you can pick up some lesions, things in the skull, tumors that are restricting diffusion. These things can all show up on the DWI. So again, just do that same search pattern, going lobe by lobe, going to the basal ganglia, and then the brainstem, and then the posterior fossa, and then the extracranial structures, looking for anything that could be restricting diffusion. Next, you'll look at the SWI. This is a T2 star sequence here, actually, which is similar. It's looking for basically deoxyhemoglobin or things that are blood products, basically. You're looking for anything that's showing up dark on your SWI or your GRE sequence or T2 star sequence. This can all indicate, old microhemorrhages or patients with amyloid angiopathy. You can see these all over the place. You'll look at the distribution. Also, bleeding structures that have bled in the past, like little cavernomas, can also show up best here on the GRE or the SWI, as well as any blood products. So that's your SWI or GRE. Next, you'll move on to your T1 sequences. Your T1 is going to be used primarily as a pre and post contrast evaluation, but also to look for blood products, things that are intrinsically T1 hyperintense, like acute blood, or melanin in the case of melanoma. So again, doing the same approach where I look at each lobe, intracranial structures on the T1 pre, brainstem, basal ganglia, posterior fossa, and then also the extracranial structures. And if I have a post-contrast sequence, I'll then, link the two and follow them as I do that systematic approach to see if there's any abnormal enhancement anywhere that I'm looking for. And I'm looking for, ring enhancing lesions, masses, leptomeningeal enhancement, subacute to acute stroke can enhance. If the patient has a history of neoplasm, particularly head and neck cancer, I'm looking at any cranial nerve enhancement, all kinds of things. Again, this is a general approach, so you tailor your search pattern depending on what you're looking for and what the indication is. We don't have an MRI or an MRV here because this is a MR brain without. But the last thing you're going to look at is you're going to do a good look at the extracranial structures, which we already did on our T2 and then our T1. But particularly if you have a sagittal reformat, this is a great place to look at the orbits, the retroorbital fat, again, the facial musculatures, the lingual structures, the upper cervical spine, the calvarium, the scalp, and then of course your midline anatomy. Make sure that there's no cerebellar tonsillar herniation or posterior fossa malformation. Looking at your pituitary gland, making sure it's not enlarged or abnormal expansion or empty in the patients with IIH. And then in this case, it's a completely normal study, so we don't have much to talk about. But we've made it through all of our sequences systematically with a general approach, and this is pretty much it for a routine brain. But again, your sequences that you expect and what you're going to be looking for is going to change depending on the indication, the protocol. But for a general MR brain without, as we just evaluated here, this is pretty much what you're looking for. So I hope you found that useful. Again, Rad-Call.com, we have all of these search patterns for over 100 different studies that you can use to kind of systematically get your search pattern down if you're learning a new study or you're a resident getting prepared for a call. Again, what we're looking for stepwise just kind of reminds you what to look for, and it's all available on Rad-Call.com. You should check it out. We'll be posting these search pattern videos weekly, so if you like this, make sure to like the video and subscribe to stay up to date, and best of luck.